Now, all of us who do thyroid operations, we do know that there are multiple quality of life issues. A lot of our patients need lifelong thyroxine support, calcium issues, swallowing issues, but one of the most important issues are voice. I work in Doncaster in South Yorkshire. This is where I practice. It's a nice large district hospital in UK. And this is where ENT Masterclass was born exactly 20 years ago. So, we have to look at voice preservation measures in two different parts. The first bit is basically the details of what we know about thyroids, and the second bit, which is very important, is the surgical anatomy. After which I'm going to talk in three sections about the pre-operative, operative, and the post-operative strategies. We all know that nearly 1 in 5, 5% of people would have palpable nodules, and if ultrasounds are done, it could be up as much as nearly 50%. And if needle biopsies are performed, the percentage of patients who have cancer, be it microcarcinomas, is significant and not to be underestimated. But if you look at the main causes of thyroid surgery, it's either cancers, or it's a benign goiter causing symptoms, or it's an endocrine cause. And if you look at figures, these are just generalized figures because the accurate updates are not available. The number of thyroidectomies performed in the United States has gone up 3 times in the last 30 years, approximately 150 to 160 per year, of which, as you can see, the majority are hemithyroidectomies. In the UK, we perform between 12 to 15,000 thyroidectomies, but the number of hemithyroidectomies are a little bit higher, possibly implying diagnostic procedures. I've just mentioned parathyroid surgery figures. I'm not going to allude to it further on because, as you appreciate, parathyroidectomy also have voice issues. So, in the surgical anatomy, we've got to have a very clear mindset on how we're going to approach the surgical field. Now, the first nerve that we encounter is the recurrent laryngeal nerve, and I'm going to talk about whether we should or we shouldn't find it when we do surgery and what are the statistics. The other nerve which is important, though may not present as openly as a recurrent nerve palsy, is the damage or prospective damage to the external branch of the superior laryngeal nerve. Now, when I mention recurrent laryngeal nerve, the point to take home is that nearly half of them would branch before they enter into the larynx. Now, traditionally, when they branch, it was assumed that the posterior branch would carry the abductor nerves and the anterior branch would carry the adductor nerves. That is not entirely true. The posterior branch usually carries majority sensory, and the anterior branch, which may appear smaller, contains both the abductor and adductor nerves. So, the mistake not to make is do not damage either. Try and preserve and be conscious that the nerve may branch before it enters the larynx. The other thing to keep in mind, especially on the right side, is the non-recurrent laryngeal nerve. Now, one tip is that if you've done a CT scan before your surgery and the report includes that you've got a retroesophageal artery, then be alert that you might have that 1% chance of non-recurrent nerve. And I'm talking about the subclavian artery being retroesophageal. So here you are. You can see very clearly when it's good, the nerve goes straight through. You've got your inferior thyroid arteries to watch. And when it's non-recurrent on the right side, you've got to be alert. It may be passing right where the inferior thyroid artery is, or it may be a little bit higher. But the one hint is that if you've got scan and the scan reports retroesophageal subclavian artery, you might be on the lookout for it. Now, as far as the external branch of the superior laryngeal nerve is concerned, you want to keep away from it. You may not necessarily see it every time you are doing the superior pole, but the best way is to stay close to the gland and divide the vessels as you do that. So what happens after surgery? Now, it's not uncommon, and I wouldn't worry too much if the patient has transient dysphonia for a few hours, 24 hours, or even up to 2 weeks. Because different studies have shown that up to 80% of patients may have some variation in their voice after surgery. And a lot of it may have nothing to do with your operation. Top of the list would be anesthetic causes. I'm going to talk about that in a second. While I've said that, one also has to keep in mind that you may have a patient who may not apparently have any dysphonia, but they may have a unilateral cord palsy. So we've got to keep that in mind as well. And we also know that up to 10% of transient laryngeal nerve weakness will recover. Now, I put some figures about the cord palsy rate after surgery, but my personal view is we have to be always guarded when we quote figures, because one, your own figures may differ from what the figures are out by different associations. But in UK, we've got the British Association of Endocrine and Thyroid Surgeons log, in which we try and put our figures in. The problem with that is not everybody puts their figures in, and not everybody does a pre-op and a post-op cord check. Now, there was a study in Denmark and Sweden where they clearly showed, looking at thousands of patients, that the number of cord palsies can double if every patient has a pre-op and post-op cord check. So one has to be a bit guarded when we talk about the exact figures. But yes, the figures of long-term laryngeal weakness is small, but it goes up quite a lot if we deal with patients who are having revision surgery or patients with infiltrating laryngeal cancer. So I mentioned the quality of life issues that these patients have. Well, if I just confine to vocal cord and voice, well, with the unilateral vocal cord impairment, you will have maybe 80% patients who may have a degree of dysphonia. They may have difficulty breathing, there will be a degree of swallowing issues, some may have aspiration. Acute airway difficulties will come almost certainly if you've got a bilateral situation. So, what are the causes and sites of altered voice? Well, the most important is the recurrent laryngeal nerve. Now, the debate that has happened over I would say the last 150 years has been, do you go looking for the nerve or do you avoid the nerve? In the early part of last century, there was a trend that stay away from the nerve and you might be all right. But then, a lot of surgeons now would go and try find the nerve and follow it to the larynx rather than not find it. And studies have shown that there is a significant difference in the outcome. So the recommendation is that please do find the nerve and follow it to the larynx rather than avoid. And the difference could be between 1.1% palsy rate to as little as 0.4% palsy rate in one of the studies which looked at it in thousands of patients. Now, the other area where you could have an issue is, I mentioned the external branch of the superior nerve. But some of us, we divide the strap muscles when we do thyroid surgery. Professor Arnold Moran in Glasgow once wrote a paper about this, and there is evidence to suggest that if the strap muscles are damaged or not put together again properly, there is a effect on the voice. And I mentioned in the beginning about the 80% chance of having problems with voice, not related to surgery, and that's where I've listed them as a non-surgical cause of voice problems post-operatively. Now, it's very important as surgeons, especially surgeons who deal with larynx, thyroids, malignancy in that area, to speak to your anesthetic colleague before they intubate. So if you've got a situation where there is distortion of the larynx or the trachea, or you know something which might help your anesthetist, tube size, etc., it's always nice to communicate with your anesthetist before they undertake the procedure, because after the procedure, the anesthetic course will cause you to have a little concern. Also, in your patient's history, keep in mind that your patient hasn't got a history of cross reflux or a hiatus hernia, etc., which may be causing edema around the larynx. So, I mentioned that the three sections, the pre-operative, the operative, and the post-operative strategies to try and get better voice outcomes. So, in the pre-operative, the first and most important is what is the voice situation of the patient on the day they come to you. And one would be your own perception, the other would be the patient's perception of what their voice is like, and then don't forget, if they've got somebody accompanying them or the relative or attendant, you could ask them how they feel about their voice. And if you have the facility, you would then examine the patient. I mean, in the past we used to use mirrors, now everybody uses endoscopes and scope if you want to. And again, the issue arises, how many surgeons do a pre-op vocal cord check before they operate? Now, various studies quote figures from 10 to 60%, but again, not everybody does it. And there are studies which will tell you that patients with thyroid nodules may have cord palsies even before you've operated on them, and you may not have picked it up. So,
3%
one thing is sure, that you would be recommended to check the vocal cord if you're dealing with patients who've got cancer, you're doing revision surgery, you've got a patient who's got an obvious voice disorder, or patient with large goiters.
Benign 1%.
It is also very useful that if you know that there's a cord palsy on one side, it may help you plan a strategy to operate on the non-paralyzed side. And of course, it will also help you counsel the patient on the consequences of getting bilateral cord palsies, tracheostomies, and all the rest that will follow. So, in the intra-operative, I've already mentioned to you that it's important to try and identify the recurrent laryngeal nerve during surgery. Some still don't, but that's the general recommendation. We have to try and protect the external branch of the superior laryngeal nerve. And then the question arises of intraoperative nerve monitoring. Now, it's not necessarily something which is going to protect the nerve. In the end, it is your skill and the knowledge of surgical anatomy which is going to help. But yes, there are studies which have shown a marginal benefit in transient weakness, that there is a less chance as compared to when you don't use the nerve monitoring. Where we work in the UK, nearly every unit will use a nerve monitoring when they operate on thyroids and parathyroids. Various colleagues have looked at it and they've shown it might help you identify and follow the nerve. It might speed up the operation, but again, at the end, it has to be your own surgical skills. But there is general recommendation when you may find the nerve monitoring useful, and I've listed it here. It would help. Training aid for juniors, I'm not sure that that necessarily is true, because if we make our juniors totally dependent on nerve monitoring, it's not actually a good habit. And I think there is no replacement to the knowledge of surgical anatomy and skill on this. Another topic which comes on quite often is what is the role of giving intraoperative steroids to these patients to get a better outcome from the point of view of if you had some damage to the nerve, etc. And the studies which have looked at this have shown that while there's a benefit on pain and vomiting, after 1 week, the outcomes are the same if you give steroids or you don't give steroids. So, depending on that alone, I wouldn't recommend. Now we come to the post-operative section of your strategy. Again, it will start with the voice assessment. patient's perception of their voice, your own perception, and how are you going to examine the patient. Now, earlier on I mentioned about the percentages of vocal cord weakness, etc. Not only we have got a weakness in the figures that not everybody does the checks, the other thing is how are the checks done? There are still colleagues who are using mirrors, there are still colleagues who are using fiber optics, some colleagues using strobes, etc. So we need a uniform measurement to get figures which would match up and be comparative. So first of all, if you're going to do a post-op voice assessment, you ask the patient or the relative. Then you could do the various examinations I've listed and perhaps even get a speech and language therapy opinion. But the question is, when should you get the true voice assessment outcome? I've alluded already that immediately after the operation there's an 80% chance that the patient might not have a good voice. So a lot of people might say that if the voice is not really good immediately after the operation, you might wait a couple of weeks before you make a conclusion where you're going with the voice. And the question then arises is, what do you do with that? So we've got the figures. In primary surgery, it could vary between 2.5 and 4.3, but the weakness in these figures has all the vocal cords been checked. It will be higher in cancer and obviously in revision surgery. So we've got a situation where we've got a patient who's got a cord weakness. What do we do with that? We've had some very good talks in the last few hours and yesterday about the spasticity that develops or the fibrosis that develops. So people have looked at the benefits of early intervention. So if you've got somebody who's got a cord weakness, it might be an idea to intervene early with a maybe augmentation injection to try and medialize the cord. And its benefits are that these patients may have a recovery and the chances of needing more substantive long-term surgical correction may not be required. And resorbable materials would be recommended, of course. So if you've got a post-op vocal cord paralysis, an early referral to a laryngologist, if you don't do it yourself, you want to pass them on to a colleague. And laryngeal framework operations would be an option if there is no recovery after initial intervention. Laryngeal innervation is also being done, anastomosis between the ansa cervicalis and the recurrent laryngeal nerve. It helps by providing bulk, providing some degree of innervation and prevention of muscle atrophy. But the weakness that you will get or the voice change that you will get with the weakness in the external branch of the superior laryngeal nerve is usually subtle, because as you will appreciate, it's the pitch and the projection of the voice which suffers. And these patients would benefit from early speech and language therapy support. So, in voice rehabilitation, it is important to recognize that it is a very important quality of life issue for patients who've had thyroid and parathyroid surgery and they've got issues with their voice. It's very important to keep the patient and their family on board, and obviously if they've got a professional use of voice, etc., you counsel them pre-op and you counsel them after the operation. Early speech and language therapy gets better results. And finally, in summary, vocal cord paralysis is a major quality of life issue. The incidence, without any hesitation, I would say is higher than what we think given out in the various studies that have been published. And you could improve your vocal cord, your voice outcomes by categorizing your approach to the patient in a pre-op, in intra-op, and a post-op section. Counseling, early medialization, and speech therapy is very helpful. And with that, I come to the end of my talk. We are invited to the ENT Masterclass World Congress, will take place in October of this year. Thank you very much.